Hello, good morning, all. Can you hear me? If you can hear me, can you just wave your hands? Let me be sure my voice is audible enough. All right. Thank you very much, and welcome to today's tele echo session. My name is Prosper Onyekachuku, and have here with me my colleagues, Dr. Naji Azuka. We have Miriam and the rest of the 5 members on the call. It's another wonderful day again, and today we are continuing with part of the session we had last week on viral genotyping. So we are looking at three aspects of the viral genotyping, looking at clinical interpretation and utility of HIV drug resistance. Thank you very much. We have the subject matter expert already on the call, all the way from Atlanta, Georgia, United States of America. But before then, want to call on the Federal Ministry of Health to quickly give an opening remark. And standing by to do that is Sabina Aika. Sabina, please, can we have you on?
Thank you so much, Prosper, and good morning, everyone. As introduced, my name is Sabina Aiki, and I want to welcome you to today's ECHO session. I am really glad to be part of the session today. And today we're going to be learning about the importance of drug-resistant testing. You're going to be learning about how it can be utilized to
Sabina, we've lost you. I can't hear you again. Are you there? Sabina, if you are speaking, we can't hear you.
get this knowledge every week. So I'm really, really glad to be part of the program today. We have a highly skilled and experienced subject matter expert on the call who is going to be sharing his knowledge with us. So I want to say thank you to him. And thank you to all the other subject matter experts who share their experience with us every Thursday. Thank you to all those who joined this call. We acknowledge your quest for knowledge, and we are really glad to be part of the process that is impacting this knowledge. I also want to thank 5 for, especially Prosper, for always facilitating these sessions. Thank you so much. So on behalf of the National Coordinator of NASCAP, Dr. Akudo Iprazu, I want to once again welcome you to today's session, and I wish us all a successful learning experience. Thank you.
Thank you very much, Sabina, for that remark, and thanks to NASCAP for all your support behind the scene. We appreciate you. Also, thanks to Dr. Basharu and the rest of the NSHIP team. Again, we want to call on the CDC representative to give us an opening, to give us a goodwill message and from CDC. And we have Dr. Dennis Onotu, who is Continuing of Care and Treatment Branch Chief for CDC Nigeria. Dr. Dennis, please, can we have you?
All right. Good morning.
Good morning, sir.
Okay, great. Good morning, colleagues. I bring greetings from the leadership of the Centers for Disease Control and Prevention here in Nigeria, under the leadership of our country director, Dr. Mary Boyd, and to welcome you to yet another SPICE ECHO session. And it's glad to know that it's a continuation of what was started, I think, about a week ago. And today we'll be looking at the clinical interpretation and utility of HIV drug resistance report. So by and large, as with the rich history of treatment within the country, and with many patients being on treatment over many years, one expects that from time to time you have a pool of patients depending on how their experience is de novo, whether as starting treatment and responding, and subsequently maybe because of one thing or another they fail, and because of mutations of the virus, may needing maybe a second line treatment from based on the finding. So it's going to be another interesting discussion, and I wish every one of us a very interesting listening, learning session, cross sharing of information and ideas, and to say that the team, the health workers across that are on a daily basis working in the forefront to make sure that the teeming population of the PLHIV in country are receiving the optimal care. I think it's a very important platform to share this information and to improve our practice and to ensure that we are delivering quality care and treatment to this PLHIV. And I want to thank the FMHQ through with NASCAP, the collaboration with CDC to continue to ensure and supporting our partner APIN to continue to deliver on this. Want to say thank you, and we'll continue to collaborate and ensure that we support this kind of platform that inform, we continue to strengthen the practice and the care across. Thank you.
Thank you very much, Dr. Dennis, for that wonderful goodwill message from CDC. So today we'll be learning, like I said, the second aspect of the viral genotyping. Last week, the take home was, for me, was that not all mutation would result to drug resistance. And I hope to get in another one today from Dr. Chika. And Dr. Chika, we are sorry, we have to wake you up to make this presentation, but it's all good. That's part of the benefit of virtual learning and the eco session. So Dr. Chika, over to you. Dr. Chika is Chief Research Scientist from Nigerian Institute of Medical Research, Lagos, currently on a course in the US. Dr. Chika, please, can we have you go on?
Good morning, everyone. Good morning, Prosper. I hope you can hear me clearly.
Yes, I can hear you.
Okay, thank you so much. It's a privilege to be here once again. I'm excited we can have this session, and I hope everyone can hear me.
Yes, we can hear you.
Okay, great, thank you. So let me proceed to make this very big. Confirm is in presentation mode now.
Yeah, it is.
Okay, good morning, everyone. And thank you once again for being here. We're going to be looking at the clinical interpretation and the utility of HIV drug resistance report. We're going to have a bit of a summary from what we looked at last week, and how to manage second-line treatment failure, how to know which drugs are possible to use for your second line or third line, and then how to interpret and use those DR reports. We're going to have quite a couple of samples here. And please, when it's going to be interactive, when we get to that point, just if you have to make a comment, unmute yourself and kindly just go straight to the point. And then we'll lastly look at steps to switching according to the national algorithm. All right, so in summarizing what we look at the first time, we try to look at the different drugs from the different classes to see their shorthand forms, so that when you see it, you can also recognize them. And like Prosper said, thank you so much, Prosper. Not every drug resistance mutation causes drug resistance. You may take a couple of them together before they cause resistance. We also looked at how to order HIV DR test. There are some things to make sure in your patient has been on drug for 6 months, has 2 consecutive viral loads that are above 1,000, the patient is adherent, and you take the sample when the patient is on the failing therapy. You will see the reason why we insist on this, why the person is still on the drugs with the drug pressure, or at most within 2 weeks of stopping that, and you ship it to us cold chain. Now let's go into managing the treatment. So this is from WHO. say your uterine viral loads, we hopefully expect everyone to be not detected. And then if someone is above 1,000, there's a cause for concern. Their countries should shift from the NNRTI-based regimen. Thankfully, Nigeria has done that. So, but that gives us a lot more leverage. Most of the people that are in DTG, they are mostly suppressed. But if you see someone who is above 1,000, that's part of when we begin to think of the HIV drug resistance testing. Now, this is the national algorithm for, this is part of what is the national guidelines. It talks about the different parts of how you can know someone who's failing, whether virologically, immunologically, or clinically. Most of the time we use virologic because it detects it quite early. When you see someone that has a viral load of above 1,000 copies, you are not waiting for clinical stage 3 or to have SARS or different things. When you see a high viral load, you begin to do enhanced adherence counseling. And then you go again after 3 sessions. So it's 2 things. 3 sessions, it used to be 3 months of drug. They said 3 sessions of enhanced adherence counseling. And if the person is still above 1,000, you have to now decide, working with your treatment team, whether the person should be switched. If possible, you go for HIV drug resistance testing. I'm hoping very soon in Nigeria, we'll have that routinely available. And then, so one of the major recommendations is that if people have HIV-DR to NNRTIs above 10%, that country should shift. I'm showing you this to show that Nigeria has already moved ahead of this, and we have already moved to first-line treatment that does not include NNRTI, that's the TLDs. And we showed this last week to show that resistance is rising all over across the different WHO regions. And so it's not something specific to people in Africa. So going into this is to know the preferred 2nd line and 3rd line regimens for adults, adolescents, and children. Now, 2 great things to look out for. What was the person on in the 1st line treatment? It's very important. And 2 things you will note here will be that the class of drug called the NRTIs are recycled in the 2nd line treatment. So if you waste time to shift someone who is developing drug resistance, they will accumulate a lot more resistance that will affect the 2nd line. It's something to note. You don't want to shift too early and you don't want to shift too late. There just has to be that middle line. And that's where having a team looking at the reports is very important. Now, if the person was on TDF-based regimen, you shift to AZT and then have a PI added. But if the person was on zidovudine, you shift to TDF and then have a PI added. So a few things for the children, basically because they may use a Abacava. Now, for 3rd line or salvage regimen, one of the greatest drugs they use is darunavir, DRV. It's good in the sense that even if there's resistance against it, if you double the dose, it will still be effective. So it's still always useful. And then there are a variety of combinations. You will see why we have this variety of combination, because at this time, you are trying to see what the patient has, what the person has used before, what resistance the person has, and you are trying to make the best of the situation, what you have. So it's going to become a bit clearer as we move on. But what you don't want is to have the person on a regimen that only a drug or 2 are active. As much as possible, you have drugs that have activity more than from different classes of HIV drug resistant drugs. Now, I have the pop quiz. I don't know if they can immunization prosper, but if someone in the next 1 minute has something to say on this, I want us to look at this drug resistant report. And I'm asking you, assuming you're a clinician and you get this report, sorry, let me interpret a bit briefly. So this is the class of this drug, the NRTIs. It lists some of the drugs here. This is the NNRTIs. It lists the drugs here. And this is the PIs. It lists them here. When you see it red like this, it means it's resistant. Susceptible, you can use. Intermediate, it's on its way to resistant. If you don't have an option, you may be able to use it. So if you get this kind of report and you want to change regimen for your patient, would that be a second or third line regimen? I want to be sure we are following with the immediate past slides. You know, we just talked about second line and third line regimen. Please, can someone respond?
Okay, so can someone respond by raising your hand using the Zoom platform so that I can enable you? You can speak until you raise your hand and you'll be enabled. If anybody want to respond or just try. I'm looking at your hands. Is anybody raising hands? Okay, so we have is the Gordian. Is the Gordian, can you unmute yourself and ask?
Yeah, good morning.
Good morning. Yeah, we can hear you.
For this patient, I can see that the patient is susceptible to zidovudine and also susceptible to tenofovir, but is resistant to the lopinavir, which is the protein inhibitor. So in this situation, I'm thinking that this person is going for a salvage treatment. That's a third line drug, because the second line drug, which we should have protease inhibitor, is already resistant in this situation. But this patient can also still continue to benefit from lamivudine, even though it's resistant to it, because of the impact of the resistant strain, what lamivudine does in terms of susceptibility to other drugs. So I think this patient is going for third line drug. Thank you. Over.
Excellent, excellent. Thank you so much. Thank you so much. All right, so we're going to delve into this deeper in the next few slides, but I wanted to make sure we see this, you know, like they have in the banking. You have some things in small letters at the bottom. We actually list the drug-resistant mutations at the bottom. And that's why we have these sessions, so that you can do further interpretation and tweaking if there's any need. So let's look at the next few slides. So I wanted to put something first. In case people don't know how to get to this, this is the website where you will have this. This is always being created. It's continually being updated. So I can't remember the version it was on when I started. It was almost like 6. They keep changing. I think early this year or late last year, it was version 9. It's now version 10. So as new mutations are being found out, it's added. So just do well to know this website, HIV Drug Resistance Database. It's maintained by Stanford University. And when you get to this website, you see these things here. So that's where you see the drug resistance summaries. You can download the PDF. Prosper will share this along with the slides, and then you can look at the different drugs even online. All right, so looking at that report that we just looked at, I mentioned those mutations at the bottom. Let's look at the 3 of them. Let's see if we can do that very quickly. So if you look at the NNRTIs here, what you see is that there's a mutation at position 103 where K has changed to N. If you look at this table that talks to you about what are those mutations, the impact, if you look at 103 where K has changed to N, it only affects epavirenz and nevirapine. That's why on that report, you see only those 2 are resistant, because the mutation the patient has developed does not affect etraverin. It's something to note. But we rarely reuse the NNRTIs. And I want to go first to the PIs. The person that responded answered correctly that this is going to be a third line regimen. You see already that the person has resistance to the PIs. The PIs are the mainstay in the second line regimen. Now let's look at the mutation the person has. It has first M41I at position 41, M changing to I. These are minor on its own. It cannot cause major or drug resistance. It has to be in combination with other drug-resistant mutations. If you look at the next one, I54V. I54V is minor for ATV, but it is major for the LPV and does not affect darunavir. If you look at 82S, you see S is minor for ATV and is major for LPV. Then all these other ones, they are actually polymorphisms, they call them on PIs have minor and major mutations. So we like adding all of it. So if you're interpreting, you can also know the minor ones because all of these will add up to whether the patient will begin to have something else. We will see that in the next slide. But what I'm trying to say here now, in interpreting this, if for some reason you don't have darunavir, or you are waiting for it to come, looking at the mutations your patient has, it will be best to have the person on ATV than LPV. Because most of the mutations, if you look at it, both of them are resistant. But if you look at them, I54V affects LPV much more, as does V82S. So it will be better the person is on ATV while you are waiting the drug to be sent or something than LPV. So this is why we include this, so that if for some reason you have to tweak the drugs for your patient, you can have something, you can interpret this and you can do something for the betterment, for the management of your patient. All right, let's look at the NRTIs. There are 3 mutations for the NRTI. And I said the guy did excellently because he mentioned a few things. You know, when I was showing the third line regimen, you saw all sorts of combinations. There is this mutation we looked at the last time, M184V. When it appears for the NRTIs, M184V, it makes them resistant to this drug, 3TC and FTC. But why it makes them resistant to these drugs? It makes the virus hypersensitive to these two, tenofovir and zidovudine. So people will often leave these drugs there to drive the mutation to keep developing, so that these 2 drugs can be so sensitive to keep the virus in check and make sure the viral load goes below not detected. Now, this is the critical thing there. If you look at this table, the other 2 mutations, you don't see it. At 62, you don't see it here. We have the major one here is 65 and 67 under the terms. 75, you don't see it anywhere. But there is something going on. And that's part of why I put up these few things. And that's why I try to show the mutations, how to go and get these mutations. If you look at the MDRs, these are multi-drug resistance mutations. These mutations, when they arise, they knock out the whole drugs in this class. And this is a major class of HIV drug resistance mutation that we use in first line, second line, third line. So if the one that knocks out everything arises, you are going to severely limit the options of your patients. But this Q at position 151, changing to M, it arises ultimately. There are some mutations that will arise first before it comes up. And these are 4 accessory mutations, A62V and V75I. So these things will arise first before you finally see Q151M arising. So it may appear that this patient is doing well, but being an expert and knowing how to interpret this, you will see that the person is already developing 2 of the mutations that was leading to Q151M. And you have to take action immediately so that we don't get to the point where Q151M comes out. And that would have knocked off this whole class of drugs. So that we take care, we don't just say, oh, it's only 184V. The person is on his or her way to developing the mutation that will knock out this whole class of drugs, and we need to do something fast. All right. So let's go further into the interpretation, and we have a bit of scenarios here interpreting the drug test, and we look at them again. So this is interesting. This is the same patient a month apart, 30 days. The person came in, I don't want to say too much, but the person came, let's say at the beginning of the month, at the end of the month, 30 days down the line, after taking the drugs, the person has the second report. So this is the first report, this is the second report. Can you discuss possible reasons and then the treatment plan? So maybe the first or second person that can just help us with this. Possible reasons, you can think of any reason that can lead to this, and a treatment plan for this person. Prosper, can you help on with them, please?
Yeah, so can anybody respond to this? If you can raise your hand, I will call you now to respond. Can anybody respond? If you raise your hand, I will enable you. Dr. Chika, do you want to ask the question again for clarity?
So the question is, looking at these two reports, the person came to you, let's say in January, and you did drug resistant report, you had this report. There was some reasons we said you have to come back within 30 days. I will explain after. And then the person came 30 days after in February. And we have this report from the same person.
Okay.
Can you discuss possible reasons for this? And then what would be your treatment plan for this patient?
Okay. Anybody willing to share idea?
Okay, maybe I should just go ahead.
Okay, yeah, somebody
Okay,
has yeah, so Ezima Guardian.
Yeah, you see me. Let me make an attempt on this one again. So I think that what led to this increase of resistance strength is that the person was maintained on the same drug, and that gave a kind of person being on monotherapy, because the other drug he has been on, he have already developed resistance in some of the drugs, and then the only one that we are susceptible, he was susceptible, he continued on the 3 drugs, but unfortunately, it means he's only on one susceptible drug, and therefore he now developed resistance to that one, because the mutation can be easier once you have only monotherapy. I think that is what led to the person having resistance to all other drugs. And because they are of the same class, once he develops resistance in a particular class, and the person continues with that drug without tweaking the drug, he will now develop resistance to this other drug of the same class if over time, like what he was explaining about different points of mutation. So in this situation now, where the person is found, we found this patient, I think the best option will be to look at the susceptibility, the drug is susceptible and the one that is intermediate resistant, and maybe increase the number of drugs. I think attacking drug in different, using different combinations, more than this situation might be for 4 drugs among the intermediate and the susceptible one, and also using also the namubudin, which also makes the other drugs super susceptible. So I think that's the area I'll be going at this point in time. Thank you.
All right.
And over.
Thank you so much. Thank you so much. So I'll just now give the scenario in the background. So this is to point out the essence of drug pressure, and to point to us it's very important for the timing of collecting the sample for drug resistant testing. This patient came to us in NIMA. The patient came from outside the country. It was during the Christmas holidays or something, came in early and ran out of, I think it was a lady, I'm not quite sure, ran out of her drugs and came to NIMA. Unfortunately, NIMA did not have the drugs the person was on, because in Nigeria, we often have limited drug options. So we said, okay, we will do HIV drug resistant testing and try and place you on a drug. But you must come back within 1 month, because we are not sure if this drugs is working, because she was on far advanced treatment that we didn't have. So that's this first report, because at that time, the person was not on the PIs. The PIs showed as if they were susceptible. This is the essence of putting that check. When you are sending your patient sample for drug-resistant testing, make sure the person is on the drug while the sample was taken. Because what we kind of do, I don't want to use the very technical terms, is like population sequencing. You are scooping. If the mutation is not present in 20 to 30% of the virus in the system, we may not be able to detect it. And that's the essence of the drug pressure. It will take away the susceptible ones and make us see the resistant one. So at that point, the patient came in not having used drugs for a while. It appeared as if the person was susceptible to the PIs. But after a month on the PIs, because that was what was available in Nigeria, the PIs have removed and suppressed the wild type virus, revealing the resistant virus, such that it was now much up to 20–30% in the system, that 1 month after, for the same person doing drug-resistant mutation, we see that the person had already had drug-resistant mutations to the PIs and shouldn't actually be on PIs alone. So these are the reasons for saying, make sure your patient is on the failing therapy while you are taking the sample for testing, so that we can truly determine the mutations present in the person. And then you can be able to change drugs appropriately. I hope this is very, everybody understands this. And then this person will most likely go to a salvage regimen. And we have discussed a bit of that earlier. So I want to discuss, if possible, 2 persons to look at these 2 drug-resistant reports, discuss your treatment plan for these 2 patients. What would be your treatment plan for these 2 patients? This patient on the left has everything, all resistant. Then this person on the right has some of the PIs available. What would be your treatment plan for these 2 different patients?
So can we have someone else? Even if it's still the same exam, we don't mind, but can someone else give a trial on your supposed treatment plan for these 2 patients? Anybody willing to try? We will soon be attaching our wall to this so that people will be motivated and then prepared to come. I know if there is prize attached to it now, we'll see many hands, but then we can still do something. As at least Dr. Chika is coming back from the US, he can bring something. Dr. Chika, no be so.
Prosper, you're a great politician.
So please, let's utilize the opportunity to respond. We can attract a special gift from Dr. Chika when coming back. I too can do something. So Ezama, your hand is up. Who knows this gift or prize may go to you? Ezama Godian.
All right, let me just make a try, because the first one is actually skipping my heart. I don't really, that first one is really very, looks like a disaster for me. But let me start from the second one, which I can look at attempt. For the second one, good 18, the PIs are still available. And the NRTI, you still have two that he has an intermediate resistance, which is ribavirin, ETR and RPV. Then for lamivudine, like we have said initially, this person can still benefit from lamivudine. So in my case, if I'm to look at this patient, first of all, put the person in lamivudine, which we have actually said the benefits. And because lamivudine will make the person to be super sensitive to zidovudine and tenofovir and co, I'll still place this person on tenofovir and then go with PI. So for me, I'll choose a PI with tenofovir and lamivudine for this patient. This patient, I'm placing him on second line drug. But in this situation, I will also make sure that I discuss with the patient for the importance of proper adherence to the drug, because any slightest, if you place with the drug, you may likely allow the other drug to become susceptible, to become resistant. Then for the first one, I think I'll do a further investigation to actually look at other salvage regimen, because this patient will certainly go for salvage regimen, because there's no combination here that will actually be beneficial to this patient as much. So we need to extend, look at other drugs that are not within here that we can look as a salvage regimen for this patient. So that's the angle I will go. In that situation, I will invite other people to actually help me with that first resistant testing. Thank you. Over.
Thank you so much. Thank you so much.
Thank you very much.
So,
Do you want us to call
yes.
one more person?
No, don't worry. Let's go on.
Okay.
There's one at the end for all of them to have a look at. So the good thing about having these things is that for you to
So
know
is he winning the prize?
Yes.
Okay.
So it's possible. Imagine seeing this report for your patients. And that's the part where I like that I am in the lab. I see this, I don't see a face, I see a number. That's where you see some doctors, they can be down. Look at the level, the numbers of mutation. Compare it to this. This person has not been kept for well managed. The person may have been left on the resistant mutation for a long time, and the person has kept accumulating mutations such that now nothing is working. Prosper, I'm tempted to ask you to, someone raise their hand now. Let's get another response from someone. Daniel raised up their hands now.
Okay, Daniel, can you raise your hand again? I also saw one Moses Waizuke also, but you raised your hands.
If they can just make their response in one minute, please.
Please. Daniel, can you get your hand up again, or Waizuke, somebody? Okay. Is it because you think the prize has been given to?
All right. So the two things I want to point out, because he did excellently. In this second patient here, he mentioned the PIs. So the only thing I will add here is check what the person was on before. What was the person's first line regimen before? So if the person was on zidovudine, you may have to go to a TDF, or if the person was on TDF, you have to go to zidovudine for this. And let's not forget DTG. We don't like to recycle the NNRTIs because they have a low threshold. So the patient can go on PIs, DTG, and then you can put a combination of these depending on what the person was on before. And since we have this M184V to drive the hypersusceptibility to the other drugs. So looking at this person too, my heart will skip a bit. I will leave this person for the experts like Professor Komi to come and look at their patient. But if you double Darunavir, you can also think of DTG and then look at some other things you can add, what you can add for this person from the NNRTIs. But this is to tell you two things. Don't let your patient stay too long on a failing regimen. The person begins to accumulate. Look at the level of mutations here. The person is accumulating so much mutation. This makes it difficult for you to choose the next line for this person. And really speaking, you have to discuss this with your patient and let the person understand what this means. And then it may help with the adherence. All right. So what are the steps in switching to a second or third line regimen? So just to list a few things from national algorithm that could be the causes of HIV drug failure. There can be viral factors where the virus acquires these mutations we're talking about, which make them resistant, or someone can be infected ab initio with a drug-resistant virus. There are also other non-viral factors, which oftentimes we don't consider. Everybody knows about adherence, but very few people talk about the fact that the patient may not actually be absorbing the drug well, or that the drug had poor potency, maybe it was not kept well, or it was not well manufactured, which may be a long thing. But also, what about dosing? Maybe the person is on the wrong dose for maybe size or something. And then think of drug-drug interaction. Maybe it's an elderly person that has to take some other drugs. And there are drug-drug interactions that are making the ARVs not to reach the plasma level that will make it therapeutic. So these are other things to check and consider. Let's not always jump to poor adherence. All right. And then when you are going to change drugs, there are two things I just need to highlight before we move to the end, is that there is substitution and switching. Substitution is the replacement of one or two of a drug in the regimen with a drug in the same class. This may be because there's toxicity, there's pregnancy, or drug interaction. But switching is when you are replacing two or more drugs in a regimen with other drugs from different classes due to treatment failure. Please, let's know those keywords, the classes, and then the possibility that it could just be drug interaction or adverse reaction while you are trying to switch out a particular drug. And if you are going to do this, the best thing would be, these are all things from the national treatment guidelines. You have to check that the person, what's the viral load of the person, make sure you have checked the adherence, that the person is now adherent. You repeat the viral load after that confirmed 3 sessions of adherence counseling, and then you'll be able to make your a decision, most likely with a switch committee to review, track what the person has been on, and help you arrive at the best thing to give your patient. So the first thing would be to reinforce adherence, address if the person has any barriers stopping the person from being adherent, and then repeat the viral load after, well, this used to be after 3 months, but now after 3 sessions of that adherence session. And then most likely have a multidisciplinary team that will function as your switch committee so that everybody can do something for, have an opinion that brings out the best. Why we are talking about this is that you are going to review the person's record, the person's treatment, what they've been on since they started ARVs, and then think of the best line to go. Okay, so, and then you may have to follow up with their contacts, their sexual contacts. So these kind of things can track people that may be prone to having these kind of things that the person has, and you now nip it in the bud before it actually develops. So ideally, in a situation where it's just a very few persons in the facility, the health worker or the doctor and a nurse. So a nurse, when I talk about a nurse, someone that can pick up the person's chart and look at the treatment history, and then maybe the adherence counselor, if you have one in your facility, who knows, can be aware of what are the person's barriers to adherence, and then you can discuss with the patient. Okay, so I'll end with this. This is case study 3. This is one of the patients. I'll say discuss your treatment plan for this patient. Thank you. I'll leave this on board and then we'll go into our discussions. Over to you, Prosper.
Wow, thank you very much. Okay.
So you can come up with your own questions or you can start answering this. Thank you so much, everyone.
All right, thank you very much, Dr. Chika, for this well-elaborate question, though a little bit complicated and abstract to somebody that is not called directly involved into the field. But for me, last section on was that I took something very important, that not all mutation will result to drug resistance, and it has sticked in my head since that period. So we want to take questions from pharmacists alike, doctors, ART persons, and all the facility folks that interact directly with the patients, drug dispensing, and all of that, that you may want to get some clarity. We don't have just Dr. Chika. There are other experts on the call. We have folks from CDC, Federal Ministry of Health, and even other subject matters experts. So I believe this is a very right platform for you to, ask your questions and get the best of response. Do we have, anybody want to ask question?
I saw a techno come on something. Raise up
Yeah, the person has dropped the hand again.
Okay. Okay, so anybody can start with addressing this patient. What would be your treatment plan for this patient?
Hello, Prosper.
Yes,
I think
please.
some people also posted question on the chat, so maybe they are not raising, but there are questions on the chat. Maybe you can review.
I'm trying to pull it. So, Dr. Shika, you can continue. I will pull out the question and ask you shortly. So, okay, now this question, Dr. Chika, can you hear me?
Yes, please.
So this question, there's a question, it says, in a situation where the patient is a chronic defaulter with very poor adherence and has never been suppressed viral load, and has never been suppressed, the person say have viral load more than 1,000 copies per mil, what do you suggest? Do I take the question again?
Yeah, I got it. That is a big problem, and that has to be dealt with first, because let's look at this. If the person failed first line because the person is a defaulter, poor adherence, the person will also default on second line. The person may also default when it goes to a third line regimen, and it's very expensive moving such people. Our experience has shown that such people may actually not have mutations, most of the time. And that's part of what happened to this person that is on the screen. The clinicians were suspecting they have mutations. They've had 2 viral load above 1,000, and they send the person for drug-resistant report. And you are seeing this. It means the person is not having mutations. It's just mostly a defaulter. In fact, one of the clinicians in our place that had this, he said that my treatment plan for this patient is cane. It means the person is not helping him or herself. I'll stop there. I saw some other hands coming up.
Okay, so let's also have Daniel Joseph. Daniel Joseph, you may want to unmute yourself now, and then shortly I will get to you. Moses always okay. Daniel Joseph, are you there? Can you unmute yourself and ask your question?
All right, thank you, Mr. Prosper. Thank you, Dr. Chika, for this elucidating presentation. It's in fact very educating. Please, I just want to ask a question which borders on viral mutation. Can viral mutation occur without the presence of an offending drug, leading to over drug resistance at ART initiation? So that the first line and or the second line. So I don't know if you got my question.
Yes, you said, can it occur when the drug is not present? Yes.
Yes. Can viral mutation occur without the presence of? Okay, all right.
Yes, there are two or three scenarios I can think of. There are 2 or 3 scenarios I can think of. If the person was transmitted ab initio with a drug-resistant virus, that's one. Or the person had developed the mutation before and they changed the treatment. Maybe it came to your facility, a new facility, and they are not sure of the person's treatment history. And the last one would be, maybe you are taking zidovudine but the mutation that develops, let me use NNRTIs, maybe something that knocks out the whole class of drug. So those three scenarios is possible. Yes.
Okay.
I'll try to keep
sir,
it short so we can
sorry,
attend to many of the people. All right. Go ahead.
All right, sir, please. I'm saying in the instance the client is an ART naive individual, can drug
Yes,
can mutation just occur like that?
yes, and that was part of the first module where we talked about the different kinds of drug-resistant mutation. There was one we call transmitted drug resistant, where the person was infected at the first time with drug-resistant virus. So think of a scenario that, okay, think of a mother that has a child who becomes HIV positive. If the mother has drug-resistant virus, the virus that will be infecting the baby could be drug-resistant virus. Do you understand? And then the baby doesn't have history of using the drugs, but already has mutation that is drug resistant. So that's just one scenario. In fact, that's just the least easily available scenario. All right.
Okay, thank you very much, Daniel, for that. So, Dr. Chika, I have 3 questions that I will take and then have you respond to them maybe in 1 minute or 2.
Right.
We have Moses Uwezuke. Moses Uwezuke, can you please unmute yourself and ask your question?
Thank you, sir. Thank you, Dr. Chika, for a wonderful presentation. I have this concern. And now we have patients, because HIV medicine has been in the country for quite a long time, and so many facilities now are available for patients to move from one facility to the other. And we see that some people can come to your facility pretending to be naive. They don't tell you the truth, no matter how you probe. Is Nigeria thinking about maybe doing drug sensitivity testing ab initio, so that we won't have this problem that people denied being on treatment when they are already on treatment, so that we don't have a wrong choice of ARV combination? That is one. Then 2, from what we know about post-exposure prophylaxis, like look at this case of a child now, for instance, that had a vertical transmission from the mother and maybe transmitted drug resistance. How will be the best? Because what we normally do is we just start the child on drug with a kind of a list that is already as documented in the National Treatment Guideline, without thinking or knowing, even though we say the high risk, this is low risk child, but we don't do a kind of deep dive to actually know whether this child will fall into that class of people that have a transmitted drug resistance. Thank you, and over.
Thank you. Dr. Chika, please, I hope you know the question. Let me take more.
Yes, please.
So we have, please, can you? So we have, can we have Solina, River State Program, Nena, can you unmute yourself and ask your question? And then Dr. Folake and State Clinical Mentor Elizabeth, I will get back to you shortly. Solina, over to you quickly in 30 seconds.
All right, thank you, Mr. Prosper. Thank you, Dr. Chika. Just a quick one, Dr. Chika, is it possible for someone who was switched to a second-line drug because of resistance from the first-line drug, and after a particular period of time, the person became susceptible to the first-line drug? Is it possible? And is it possible? If it is possible, is it wise to still go back to that first-line drug? Thanks, and over.
All right, thank you very much, Solina. Then we have Dr. Folake Epin. Can you quickly unmute and ask a question in 30 seconds? Please go on.
Thank you very much. Good morning. Thank you, Dr. Chika. I actually asked the first question that was read out earlier on, but I have a concern, and it's about dolutegravir, use of dolutegravir. You know, currently in the program, almost all our patients are on dolutegravir, including pediatrics, you know. And from the few cases we've seen, we are beginning to see a number of, you know, failure in question or in quotes, because we've not done resistant testing to be able to ascertain maybe there are mutations and all that. And I saw that no mention was made about resistance to dolutegravir. So I want to know, for this kind of patients who are on TLD, for example, and they are, you know, they are confirmed to be adherent, at least in their own words, but they have never been, you know, suppressed or undetectable. What's your take, sir? Thank you.
All right, thank you very much. And then the last person, which is State Clinical Mentor, Elizabeth Ubioha. Elizabeth, please, 30 seconds.
All right, thank you, Prosper. Thank you, Dr. Chika, for this important presentation. Please, I want to know, because in my facility, we have some clients that are not ready to adhere. They are chronic defaulters. They're not ready to come. We keep encouraging them to take their drugs, and they're not ready. And when you do viral load for them, it's always high. In such a situation, what do you think we should do? Do we keep prolonging the medication, the first line, or what do you think? What's your own take on that? Thank you.
All right, thank you very much. And that will be all. So let's have Dr. Chika respond to the questions and we'll be out of here. Dr. Chika, over to you.
Thank you so much, everyone. So,
Dr. Chika, do you want to stop sharing your screen?
Okay, all right. So the first one, I really, in fact, there was a question also I saw on the screen, and maybe I should join that with the last question. Okay, I'll take them last, and then I'll invite someone to also say something. So, and then I also want to say, I don't know if Prof. Sakomi is here. Prof, feel free to come in at any point. So in a patient moving from facility to facility, and then you are not sure what the person has been on, I think we will have those at the policy level help us address it. I know the government is trying to develop what do you call databases that are interchangeable, that people can see things. I don't know how far it has gone. That will help us such that no matter where the patient goes to, you can actually be able to assess the person's drug history. So please, anyone from Federal Ministry or the USCDC may want to speak to this. The second one, the child with maternal transmission. So how do you place the child on treatment? So one of the things without having drug resistance would be to look at the mother's drug history and then avoid any drug she may be on. It could just help in that scenario. That's what I may suggest. But most likely for children, we are trying to set up something that will make at least them have access to HIV-DR, because if they are going to be on these drugs for life, we have to start them optimally. And most of the time, they need to start on second line already. If they're starting on second line already, they don't have much again to go with. Anything else may be salvaged, and that they still have their whole life ahead of them. So it's a scenario where we need to take and put as much care into the scenario, into that checking the patient and make sure the patient is on the best treatment possible. Now, someone asked, the treatment has moved to second line, and then you saw it can move back. Very interesting. I like that. So there was a research we did, is out there. I don't have the paper up in my head. So we had some, I forgot the number, but 100 and something patients that actually had all those things we used to call drug resistant mutation, 2 viral loads above 1,000. And at the time, they put the person on second line. But by the time they did DR mutation, they saw that the person actually did not have drug resistance at all. I said 80% of them did not have drug resistant mutation. But what happened eventually, by the time they became adherent, they resuppressed the virus on the same treatment. And that was what made us very interested. Let's pick these patients and go and look at them. We found out that they didn't have, 80% of them didn't have any drug resistant mutation at all. So it was an issue of adherence. So the person can easily go back to the first line treatment. And DTG, one of the things that happened is that all this while we have not had drug resistance assays for DTG. But now we are in the process of validating it, and very soon the country testing that will be done will be having results from DTG. And I'll just also end with the question on the screen here. There are two, so the patient that fails after 6 months with viral load as high as 233,000. And then after 3 months again, you do the viral load is 250. I want to ask you to actually check. There are possibly that it's possible that something is going on that is not just the drug. When people fail with such high viral load, something else may be going on in the background. For instance, maybe the drug may not be being taken very well. Is there issue of drug resistance? Well, not resistance, drug not reaching the therapeutic level? And possibly is the person actually taking these drugs? When the person fails, oftentimes the mutant drug does not replicate fast enough. But when he had this kind of high viral load, it means something else could be going on in the system, which may not just be drug resistant. So when you see this kind of high viral load with your patient, best check there may be other things in place. So at this point, I want to refer the chronic defaulters to Dr. Connie. I know she's here, and then the ones about the different facilities to any of the Federal Ministry of Health or CDC. I know Dennis has raised up his hand, and also Dr. Connie has raised up their hand. Would you want to enable them?
All right, thank you very much. Let's have Dr. Dennis to notify. Dr. Dennis, please, you may want to go on.
All right, thank you, Dr. Chika. Good to see you again.
Thank you so much.
Yeah, so yeah, I think you've done justice to many, but just let me ask one, just to add one or two things. For patients, that concern is really valid that people do migrate from one facility to the other. They present themselves on another facility as if they've never been on treatment, and there's nothing much can be done. But within the program, we are trying to put in place, all right? That's why the biometrics, we have the coverage, I think virtually over 95% of our patients on treatment have done their biometrics. So what is now is to have a kind of interoperability so that the data is available, so that as you move from one side to the other, by the time they do your fingerprint, even we're trying to improve the infrastructure to that even when you say you're a new patient, before they even enroll you, when you put your fingerprint, the receiving site will know whether you have been enrolled somewhere before because of it. So that's is being worked on very soon. Maybe I don't know how long, but there's a team, the national program with the team of experts within the partners and phase 3. Yeah, they are working on that to see how that can happen. So to reduce that challenge, really, that's on that bit. Then also for DT, that question, which that you just made reference to, even though the person said they've worked on adherence, human behavior can be, they may tell you they've adhered, you cannot, you've done the 3 adherence sessions, they may not be adhering. That's one. So, but that doesn't also take from what you said, which we also put in place. That's what we call there's a surveillance now to make sure, because DTG is just about 3 years or so that have been really rolled out massively to ensure across our country to begin to look out for possible resistance. Yes, but it's a drug that is very high genetic barrier to resistance. So the likelihood that it is resistant is small, but that doesn't mean that in the long run may not get to that point. So a surveillance is being done across the program globally to begin to look out for possible resistance. And there's options. If it's true that it's confirmed that it's resistance, there is a second line in our guideline. If a patient that is failing first line that is DTG based, have an option that can move on to if they've not taken it before. So that is also there. The other bit I want to say is just a word of caution for each of 3 adherence sessions, all right? Enhanced adherence session. So even it's also equal to 3 months, really. So if people don't just say within a month, I've done 3 enhanced adherence sessions, and you go and say no. So that you can give time. If they're really issue of adherence, they have quality time to be on the drug adhering. So you can, when you do that for 3 consecutively at each month apart, then at the end of a 3rd month, you can say you have ample time for those drugs to work if it's issue of adherence. And when you take a viral load, you can be able to add, use it to interpret what you are finding. But if you just do 3 sessions, maybe within 2 months, you have done 3 adherence sessions, and you have not given the drug, if it's issue of adherence, to work really, so that you can have, you can interpret. So just to put that caution there. I also advise that each ART site, so that clinicians will not be switching as well. We've come a long way in this ART program. As there was a time we have multiple drugs, there's all sorts of funny combinations people are circling. Thank God for fixed drug combination, and thank God for TLD and all those things that have kind of streamlined. At a point, we have regimen lines that are over 20 different times, funny combinations that doesn't. So we need to be careful that people should not individually just switch. Let that be each side to have a second line switch team, so that they can discuss and have a robust discussion and say, this based on this and this, we are moving to this. So each individual will not just be switching. It has, and for 3rd line, definitely it's a national 3rd line ART switch committee that will make those decisions. So just to put that there. Then finally, there's something I wanted to say about they say the issue of resistance. Somebody mentioned that, can we introduce that ab initio because of that new people moving from site to site? I think we cannot do that, because even though that are genuinely failing, you don't even have resources to test them, to do their genotype resistant testing. So it's not something we can do routinely to use to screen before you go into enrollment. So I think I'll just leave it at that. If there's any other thing I miss, I think I'll talk about that. But then one more question, sorry. To put this caution there, that's a patient is infected with HIV doesn't mean that he may not be able to, that is infected with a susceptible HIV infection, if it's not also preventing issue, and if some may get infected again with a resistant type. That's why we only promote prevention for positives. That you are positive, some of the patient is positive, taking drug religiously, doing well. If it's not also preventing, so you don't know what the other person is having, and the patient go and take in, the resistant one can overshadow, because the drug the patient is taking may not be protecting or suppressing that one. Resistant will multiply, and over time, the person may be. So we need to be careful with secondary infection from resistant strain, because also people this education need to be there for people. I think I'll just stop on that. Thank you.
Thank you very much.
So much.
Thank you very much.
Do you want to bring up Dr. Akani?
No. We are already out of time. And then
all right.
I think Dr. Akani is also not on the call again, but for salvation of time, we need to stop. So thank you very much, Dr. Dennis Onotu. Thank you to Chika. We are sorry to have woken you up this early morning on the part of your world. And to all the persons that ask questions, especially Gordian, just get Dr. Chika's email and follow up with him for your prize. Even if it's a chocolate, just something from the States. So let's have Labake give a clue. Okay, I suppose, Dr. Dennis, that would be a final word from CDC, or I guess this would be a final word for time, so that we can.
Yeah, it's fine. It's okay. I don't need to send it. So thank you all. It's been a rich discussion. Bye-bye.
All right. So can we have you give a closing remark, Labake, from the Federal Ministry of Health? Labake. Okay, Labake, you can unmute now. You can unmute now. Labake, are you there? You can unmute now.
Okay. Yeah, I am. Thank you, Prosper. Good morning. Good morning, everyone. My name is Omolabake Okunayo. I would like to appreciate Dr. Chika Nwama. Thank you, sir, as always, for sharing your wealth of knowledge with us as usual. Thank you. This is very, mind-blowing, and also it's very educative. And I believe we've all learned from the second module and the third module. I really appreciate you, sir. It's very comprehensive. And also to all our participants, thank you for being on the call up to this time. We really appreciate you for usually joining the call. And also to all our IPs that are supporting, we really appreciate you. And also to Phase 3 team, thank you for always being there. And also to CDC, thank you for your usual technical support. And to all our national clinical mentors, NASCAP colleagues, and all other persons that I'm unable to mention, thank you all. We really appreciate you for usually joining the call. So therefore, on behalf of the Federal Ministry of Health, the leadership of NASCAP, Dr. Akudo Ikpeazu, and the Head SI, Dr. Adibobola Basharum, we really appreciate you, and also wish you all a wonderful Thursday. See you all next week. Bye for now. Thank you, Prosper. Over to you.
Thank you very much, Labake, and thanks to NASCAP. And from all of us here at Phase 3, we want to say thank you very much for joining, and then we look forward to having you again next week, where we'll be looking at another interesting one. Please do take care of yourself, and bye for now.